Yeah, the topic you gave was AI and health and fitness. So sorry about that.
Okay. So I guess a couple of things that I can cover will be that where we're seeing the greatest uh, growth within healthcare, particularly in AI, is one with performing procedures and using for simulation training, and then two is also in wearable technology and what's possible, particularly with that, like I know the Apple Vision Pro. But first, I'll start with how AI is informing healthcare. There's three particular companies that are kind of leading the pack. One is a company called Glass Health, which is focused on automating the workflow and documentation for doctors and nurses. Within healthcare, anybody that works in healthcare knows that the number one task that takes most doctors' time, as well as nurses, is documentation. And so Glass Health developed a technology where it does like a record to write or speak to write feature where you could, while having a conversation with a patient, it can actually fill in all the documentation blocks during that, just in that conversation by recording it. And the second one is, pardon me, is another company that, but with the founder Marcus Allen, started Clinical Squared, who y'all may actually be familiar with. But his technology focuses on actually, so like during the pandemic when materials or having to order masks, inventory for the hospital, but also scheduling and workflows, his technology actually aggregates all of the healthcare, the health system, and all of its process, most of its key processes, particularly around inventory management, materials ordering, scheduling, and staffing profiles for hospitals to be able to automate and healthcare systems to be able to automate that process. Most recently, I saw Google, particularly in Philadelphia, Children's Hospital of Philadelphia partnered with Mastery Schools, and then I believe they partnered with a AI training slash AI like skill workforce development skill development like cohort program to be because there's shortages within the workforce around particularly nurses, medical aides, medical assistants, CNAs. They've been retraining the workforce on how they can actually do more with less, and artificial intelligence is at the center of that, whether it's their emails and communications or the patient journey and patient interactions, or even just automating the customer support slash triage process with communicating with patients and such. One last piece I'll add to it is where I think AI is taking the forefront is with how simulation training can be done. So at one point you had to use a pig or a some type of like animal of some sort to do like whether it's dissection or just to be able to analyze various parts of the body or a carcass. And now with the Vision Pro and augmented reality, there's a whole push towards being able to simulate that with by way of um, almost like with sensors where you can shape the actual like looking at an individual, and the Vision Pro can actually create that augmented line and then actually give you instructions on whether it's providing insulin or cutting or giving an IV or giving a shot. All that can be done in real time with augmented reality and virtual reality. And so the question that I think has been at the center of everybody's minds right now is whether or not AI is taking everyone's jobs. And it is happening in healthcare, but it's not taking everyone's jobs. It's really like a process of relearning, unlearning, relearning to learn again. And I think at least with what I've seen, I would imagine that California is probably leading the front, but um, Philadelphia has been making tremendous waves in regards to partnerships as well as creating a youth career pathway to not only make sure that adults are up to speed, but also to make sure that the future youth are trained and they're 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 uh, they're introduced to these skill sets rather early on, in their like middle school and high school time frame, to where they can actually be placed to address the healthcare shortage, by way of making sure that they're trained and skilled up. And probably about 40%, 50% of their curriculum is based on how they're using artificial intelligence, to actually be more effective, efficient, and productive within the workplace. And that's specifically with Mastery Schools and Children's Hospital of Philadelphia. I know that they launched something in, I think it was, Massachusetts, Detroit, Philadelphia, and there was a few other places that launched a similar initiative around creating workforce development, youth career pathways, and then also the integration and the intersection of healthcare and artificial intelligence. I'll stop there, and just before I continue to with any questions or anything that I may be able to address.
Yeah, I do. I do have a few. Well, one major question is that you mentioned about how in this industry right now it's taking jobs. Or in somewhat you know doing that, right? But in my experience, it's actually the opposite. A lot of because of all the hallucinations that's going on with the models and the predictions and things of that nature, there is a trust factor that's kind of holding this technology back, right? People want to do it, they are interested, but once you hear about because when you leverage AI, you're leveraging in a lot of critical sort of, industries, right? Whether it's recognizing images and things of that nature, because this is high intelligence. It's not your regular automation or regular type of, technology, right? So my question would be is how are they handling hallucinations? Because that's holding a lot of my clients back in terms of really diving in. And they're like, man, we can't afford to make mistakes, especially in healthcare. We can't afford to get it wrong because if we get it wrong, there's lawsuits, there's reputational damage, there's tons of money that we have to dish out. So I guess, I don't know that we are there yet simply because of this fact, kind of holding this thing back. Have you seen that, or how have they been able to address this problem? Because in my field, it's kind of a major deal, right?
Mm-hmm. No, great question. So I can speak to probably two hospitals that I've observed, particularly my time spent at Penn Medicine when this was at the forefront and simulation was. There was conversations around how do we improve the skill set of not only nurses but also doctors. When you say hallucination, I just want to make sure I'm clear. How are you defining that?
Yeah, so basically, if I am making predictions, based off of, let's just say I'm looking at a bunch of different images about, cancer, and I'm trying to extract that document and having my AI engine, really say, oh yeah, this is cancer, this is not, something along those lines, right? I'm just giving a specific example. That, it could be wrong. That prediction could be
Right.
absolutely wrong. And obviously, there's a human in the loop component that is verifying some of these results. But we're going to get to a place where, if it makes 5 or 6 good predictions, people start getting lazy and be like, yeah, I think it's got it, and just push things through. But eventually, there's a hallucination involved there where it can be flat out wrong. You know what I'm saying? And that is where the fear. It only takes one. It only takes
Right.
one.
So I can when I was my time, I think I was at Penn Medicine in 2019, 2020. I can
Yeah.
share with you what some of the conversations were around then, and
Mhm.
probably how they may be taking form in life now. And so, in 2020 and 2021, the primary conversations was around process improvement and
Mhm.
prioritization. And then the second was simulation and virtual reality being or gamification, and being able to train up and skill up the next generation workforce of healthcare workers and leaders. One of the things that was a case for whether it's the introduction of robotics to do surgery or even the use of AI and trusting technology was they compared it to the same way, when they did the robotic grand grandmaster in chess. And so when they started looking at how many options, whereas a human, well, let's just say a doctor, what their capacity is to be able to diagnose and understand and see patterns was far more limited than when you look at like a grandmaster in chess that has that all the moves downloaded and all these previous games downloaded to it, where it can start recognizing patterns and see millions of moves within seconds, whereas the human is not able to do so. And so there's a greater likelihood to misdiagnose or to and my mom, as well as probably a small circle within my group, have acknowledged this whole thing around the doctor when the doctor's diagnosis was inaccurate or they couldn't find or see what was going on. So advocating for one's own health. There still was a greater trust in technology and machine learning to be able to recognize those patterns because of the sheer volume and data that could be downloaded to it. And there's things that it's almost like if you play any chess online and you put it on super master mode, and even if they're playing even if the opponent is playing at a handicap, the computer can still recognize and set up moves 5 and 10 steps ahead that even without its queen, its rook, or whatever, that can still beat the average person. And so the same kind of thinking and rules apply with when looking at a diagnosis. Like, well, how much do I trust this doctor who's only seen this subset of patients who may not recall or may have not seen it all, to the computer that we've downloaded a million different cases of, and every kind of disease, where it can start even analyzing and seeing things and predicting from a predictive analytics stance, predicting, and then you can download the medical history of the family history, and that can even add further insight to be even more accurate around, catching things early, or being able to, or how this person should go about, maintaining or preventing or being prescribed whatever as it relates to their health. So the human, me and my ex-girlfriend argued this to the T, which was the doctor can be replaced. And that's kind of what, not to say, from a human interaction, you still require and need that. And there's been plenty of studies that show that, people don't want to feel like a number as it relates to the patient experience. At the same token, the doctor can't beat Google or generative AI when it comes down to churning out quickly and figuring out, somebody's whole entire medical history and being able to reference hundreds and thousands of data sets that it can kind of tie into to say, this is what is probably wrong. So did that answer your question?
Yeah. Yeah, it did.
Let me add a little
bit.
I
want to go ahead.
Go ahead.
Well, you guys go. I just wanted to say something quickly. A couple things. Great point about hallucinations, but I want to add a little bit of clarity for the room. Well, when you talk about hallucinations, there's a difference between hallucinations and false positives. I think the description you gave was one of a false positive, and that's going to happen with models where you think is correct, but it thinks it's correct, but it's not, etc. And the way we handle these things, I call it proximity to the decisions. The more accurate it is and the more you trust it, you move it closer to the decisioning. If you can really trust it, you can automate the decisioning based on the model. If you can't, you step it back and you insert more humans at the end. And as AI evolves, we're going to do more of that. So it's proximity to the decision. So when you talk about models and false positives, the model gets it right, it doesn't get it right. That's pretty much been around since we just been on this AI thing or statistical modeling. But when you talk about hallucinations come into play when we're using Gen AI, these large language models, a la ChatGPT, Claude, and we're trying to get information from them. Now, hallucination is the process of a model giving you information that sounds factually correct, but it's inaccurate, grossly inaccurate in most cases. So how do we handle that? Okay, hallucinations have been a problem. Now, I'm like the founder of a tech company that's going after Industry 4.0, Industry 5.0, and manufacturing, smart manufacturing. Hallucinations, we're using Gen AI to help solve a problem. The way you combat hallucinations, aside from the fact that, again, you still You trust, but you don't trust blindly. But what you do is you tighten the question and you have it as fact-based as possible. Plus, there are techniques called, like, for example, RAGs, where it's retrieval augmented generation, where you can actually provide context. I'm saying all this to say this. This applies to AI in general, specifically to Gen AI. There's a difference between knowledge and intelligence slash reasoning. Joshua, the point you so eloquently made speaks to knowledge, and you are right. The AIs, particularly these large language models, we can't compete with their knowledge. Their knowledge, they have more knowledge than the individual human by orders of magnitude, by an order of magnitude. But their reasoning by default is comparable to that of a 3-year-old. So what separates one AI from the next is how you teach it to reason. That's where advanced prompt engineering comes in. That's where using these techniques like RAGs comes in. The better you teach that model, or you guide that model in reasoning, okay, reinforced learning, rewarding the model for giving you a correct answer and penalizing it for not, okay, adding context to your prompt, being very specific about how you ask what you ask it. If you do those things, your power with an LLM is near limitless. Okay. But again, that takes a lot of work, a lot of experimenting, and we're still working on that. The narrower your focus is with those models, the more likely you are to get the right answer. So we say domain specific, but at the end of the day, models and AI cannot beat human reasoning. That's why humans are safe. Until we can mimic the human brain, which brings along human reasoning, which is another set of problems, we won't be able to take human out of it. So I think that it's just going to be a problem, a challenge. Is it right?
Yeah, you're right. I think I was applying, obviously hallucinations and false positives are different.
Yeah, exactly.
I was,
And they're in the same bucket. They're literally in the same bucket.
They're different when it applies to different. I understand.
Yeah.
Well said. I appreciate that that context, right? But ultimately speaking, I think the point that you're making still remains the same, which is that AI is great at the sort of intelligence piece of it, right? The knowledge piece of it, but then the intelligence being able to fuse that and leverage it for something is something that humans still need to be in the loop of, right?
Use AI for the first 80 miles of the 100-mile journey. If you do that alone, you're going to increase efficiency, productivity, solve massive problems. Keep humans at that last 20% when it comes to decisioning. And that's what we do. Just keep the humans at the 20%, let the AI do the heavy lifting on that 80.
100%.
Now,
right.
Curious, a divergent thought would be downloading all of the medical malpractices and all of the cases where, let's say a doctor fudged or messed up to that model, or in a training stance, would that be able to correct or increase the reasoning if it has all the cases of failure or medical malpractice to kind of match its knowledge?
Yep.
Let me show you how we're doing. Sorry about that. How we're doing it. And I'll say this quickly, how we're doing it in our space, and a lot of people in the medical space are doing it as well. So you say you have all those medical malpractice cases, right? What I would do is I would download all those cases, and I would do what's called vectorize them. We'll put them in a vector DB. And then when you go and you ask this LLM, just flat LLM, it doesn't even have to be a specially fine-tuned one. You ask it, a question, but before you ask that question, you query that question in this vector database. So it'll pull all the relevant data, okay? And then it will ask the LLM that question, but it will cite this data as context. So that increased the probability of it answering the question correctly relative to the situation. The accuracy goes up tremendously.
Right, and it almost makes me think of like that Delta approach that they take in healthcare, where it's like what went well, what went wrong, what could have been better. And so if there's sets that are downloaded that are what went wrong, then what went well, and then what could be better, that may almost, I feel like, would create that greater reasoning or accuracy with being able to kind of identify where and when certain things applied and when it may not be as relevant.
Right. In prompt engineering with LLMs, and this is the last thing I'll say, but in prompt engineering with LLMs, you could literally state the history of what went wrong. Okay, you can turn around and get context like we just described before, and you can feed it all of that, and you're literally teaching it to reason like a human. You can take that and you can use that what went wrong method, that delta method, and you can add it in your prompt. And you can use, like, for example, tree of thought prompting, where you go through steps and tell it how to reason. Feed it to the model, and your answer again will be super accurate, because the reasoning it will use will be more closely to ours, as opposed to flat asking it a question, expecting it to give you an answer.
Right. Right.
Okay. I think someone raised their hand. Go ahead and ask your question. Yeah.
Yeah. Hey, brothers, how you doing?
Good.
Man.
What's going
Good.
on?
How about yourself, man?
What's going on? Let's go. Get the energy in the room. So listen, I love this conversation. Just briefly, so to give context, so yes, I agree with all that's been shared. My background is in medicine, public health, and health policy. And so what I'm doing, so I'm using several Gen I tools, right? Claude, Perplexity, ChatGPT, Gamma, Gemini. So and of course, I'm using it to determine which one of those best suit my purposes for my goals, right? Now, I have a dissertation that I am looking to use as a framework for future studies. I am currently affiliated with the National Institutes of Health, and I have access to their All of Us program data. It's the most diverse data set currently in the country and perhaps in the world. And they are looking to work with the UK and other places around the world to aggregate and disaggregate the data such that it helps patients who don't have access to um, trial sites to be able to support research. And so my angle in the AI space is looking at coronary artery disease and social drivers of health. And I found in the literature that if I use an AI enabled tool or a statistical analysis like random forest, that has been found to be better than the traditional regression models in terms of mitigating bias, to ultimately help to treat patients at the bedside. And so I am literally in the nascent stages of structuring my study to compare how an AI enabled tool can potentially be better at predicting incidence, prevalence, outcomes for heart disease. And so what I'm doing is I'm literally going to drop my entire dissertation in ChatGPT or in Gemini and say, okay, and then with the prompt engineering piece, okay, now here's what I want. Here is my context, my entire study. Let's prompt engineer very strategically as to how do I take my frameworks and my approach and map them into an entire new data set, but this time use an AI tool to determine if this approach produces and or predicts better health outcomes. And so, because ultimately what I'm trying to do or get at is how do these approaches that are AI informed and enabled better at helping to shape policy, right? So I just want to kind of put that out there in terms of like what I've been covering.
One piece that I think would also help from the prompt side is operationally defining what better outcomes mean, because better can be relative or left up to decision. So if there's a framework around what better looks like, or that being defined specifically, with like SMART goals or measurable outcomes, then I think that how it informs the data that it generates or whatever it populates, it may be more targeted if it has
Right.
metrics to associate with better.
Correct. And so here's where I'm going with that, right? So I am going to help to create score rubrics or scores or um, indices or clustering matrices that can help to quantify what types of social drivers of health are impacting Black patients more so than others. And so it's how do I structure my study to come up with models or scoring rubrics that actually could potentially be used as a pitch to insurance plans or to hospitals or clinics, right? That is rooted and grounded in a biased, kind of mitigating framework and approach that can benefit Black people as it relates to heart disease. So yes, I am being very specific and targeted in my approach to the wording, the language, the sequence of feeding the Gen AI tools to ensure that at the end of the day, okay, can I come up with a better score or a software as a service or some other tool that can be licensed, right, for that can benefit us in a variety of ways.
Right. Quick question: do you have a host organization to pilot, and when would you want to pilot by?
Not yet. So my goal currently is to get this paper published by the end of this year.
Okay.
So there's a way there, right? So, but in the interim, I am having key conversations and trying to connect with some key people to help shape this approach, this study, to ensure that it has maximum impact.
Right. I think you already have the specifics and like the formula and the concept. I believe that having an organization, whether it's a hospital, and I can think about like who I know, but like if there's somebody where you can kind of get free reign to be able to test and get feedback on the question and just test it now. At least what I'm saying with one of the teams that I'm working with is when we went to go deploy our dashboard and everything, and then we got in front of the client. There were so many things on the back end and just how that system communicated, and then what it was spitting out that we needed to look at again. So we found ourselves doing like almost like a phase 4 launch. And so what my belief is, rather than building it but testing it in tandem, will probably be your greatest advantage with a system, to where it can inform things. Because if you get too far along in the build process and then you go roll it out and then it doesn't, or it does something else that you're not anticipating it to do, or there's inaccuracies, you can course correct that along the way. If we can do short spurts and get it in front of the right stakeholder of who you would either sell this to or who this product would be for, and then start getting their feedback from the team that would either be using it or somebody that is trained to be able to look at bugs and fixes along the way quickly.
And Joshua, if I could jump in here, guys. So same thing working with Ethan. Like my background is technology, mostly financial services and that kind of thing. And I want to start, I came in late, tail end of the first conversation or the first part of the conversation, Joshua, where you were asking about hallucinations and things like this. And look, this is what I teach people: garbage in, garbage out. It's just that simple. And as much as you can train it, to make sure it takes those different considerations, or it's taking those things into consideration when you're actually doing it. Dr. Inya, is it?
Yes, Anya.
Inya, okay. As much as you can give it to train it while you're doing this. And then Joshua, to your point as well, what you want to do is you want to get an organization that you can build a sandbox area in where you can play with these things to the extreme before you're touching the network. And Joshua, what that does is it brings up the point also. Another thing I'm thinking, people are so afraid of this stuff and they're saying that we're going to be eliminated, but there's a huge element that we're continuing to forget: the QA portion of this. The QA portion is going to be huge. where you're the gatekeeper to understanding whether or not the outcome was correct. Did we put the right elements in to get the right answer? So that also creates for you an opportunity to get some people on board who are not only testing it, but they're also understanding what you're doing. So now you've built out a small team just through playing in the sandbox.
Absolutely, absolutely. Because I mean, as y'all probably have already seen, when it's time to do the rollout, and if people haven't really spent time in the environment or with the product or with the tool, the easiest way to create disengagement is a person that doesn't know how to use it, or they feel like it's too complicated. And so another part that seems to be coming to mind is the user experience in that feedback and testing of, is this easy to follow? Does this make sense for the user? So I would ask Dr. Enya, or something to consider, your customer persona of who would be actually using the tool, or who is the product for, and what is their mindset or their approach, or is there any themes or consistencies across that customer persona of them using the tool, and how can that be shaped, their experience, their user experience, in combination with what the tool can actually produce and do, but in being able to inform their user experience. And they're also in those like short collisions with rolling it out, there's key feedback or probably custom insights that you might discover that clients may particularly be focused on or need as it relates to whether it's a healthcare system or something around I could see universities, maybe like a university, when you think about diversity or first generation low income, and then being able to look at the data set and predicting outcomes at a teaching, you could partner with a teaching hospital, which Baltimore, Philadelphia primarily services Black and brown communities. And so oftentimes there's like 3 areas where bias occurs, not only in just mindset, but also in delivery, like the communication. Like I got to send the study, but like when somebody finds out, or if a doctor is delivering that someone has cancer or a serious disease, how that doctor delivers it may be very much based on their own bias, and whether it's callous, cold, or whatever. Second piece is teaching hospitals, where it's used in tandem with the classroom or school of medicine or school of nursing in combination, or school of public health in combination with the delivery actually within a hospital, the actual hospital or the clinical setting. So you have the teaching component, and then you also have the actual delivery, or where it actually will be taking life and applied, which would be in the hospital setting. But I would think a teaching hospital would be a great, and probably like Johns Hopkins or maybe University of Maryland. I can look at folks and see if there's anybody we could connect to the conversation. One other question was, when would you want to pilot this ideally?
Yeah, so because of the different moving parts and the process and what I know about getting published and the way that I'm trying to move, potentially sometime next year, because of the variety of stakeholders that are going to be involved in this, I really want to do it right? And so while right now, as I noted, I'm in the very nascent stages of like brain dump, just trying to get stuff out of my head and trying to have some key conversations to just get some clarity about what are the specific variables, different elements that I want to make sure to incorporate into the narrative that I'm drafting, and then kind of create a dream team, of sorts that can help shape and ensure that as this evolves, that it's capturing enough key intel, key data, key touch points, so that it has maximum impact. So that's my current kind of thinking as far as time frame. Yeah.
Doctor, I was going to ask, Phil, why don't you come back next week or the week after, and maybe we can set aside part of the hour to do some brainstorming with you. Do you have any?
Yeah, that'll be cool. That'll be really cool.
Yeah.
Yeah. So, yeah.
Like code and some data. Maybe we can help you to think about what are the best ways to interrogate a model, or to put together a prompt, or you know, we can help you brainstorm it at the very least.
Okay, good. Yeah, yeah. I have an outline. Yeah. Okay, good.
Also,
that would
in
be
my
awesome.
background,
You mentioned a few hospitals up there. I know I've done some consulting for University of Pittsburgh, and also they're willing to help, particularly minority partners in this space as well. So that's another organization that you want to look at.
Okay.
Definitely.
also,
And
I wanted to just quickly inject in there. So everything you're saying is absolutely amazing, and I think the potential is massive. But the challenge that we face, and that was what my presentation. I'll eventually get around to doing it to you guys. My presentation was about productizing AI. It's such a wide sea of opportunities and possibilities, and you're a smart guy. And I think that the challenge is you have to figure out, and this is something for you to decide, what's going to be your win. Okay, because you can't think big product, and this is speaking to what Joshua was saying. I think, and correct me if I'm wrong, Joshua, the meta thesis is you need to have something that's testable, measurable, that you can validate, that you can go to a potential customer and say, this is what I have in one sentence. What's your
Right.
thesis? One sentence. And from there, I mean, from a vision perspective, all the other pieces fit in, but you can't execute on vision. You know what I mean? So I think that what to Keita's point, what we can help you do in addition to brainstorming is, and again, my background's in product, and this is what the mistake or the challenges I've faced in my career. I can help you along with the guys figure out what is that MVP and what does that MVP look like, you know, and that's going to help you out because what that's going to do is that's going to lighten your workload, bro, because you don't want to be thinking about eating the whole elephant.
Right.
You know what I mean? And then you come up with a simple value creating MVP. And from there, you go to the University of Pittsburgh Hospital, or you go to Joshua and say, look, man, this is what my MVP looks like. This is what I'm doing. He can translate that. Any of us can use our network to translate that into a simple problem statement. And from there, it's just about testing and validating, measuring and moving and iterating. Makes sense?
Yeah. And, you know, and I'm real clear on not needing to boil the ocean, right? So,
yeah, exactly.
Yep.
Also, one thing I would also add would be if maybe taking the design thinking approach. So adding, if there's a way to add stakeholders early on to the conversation while you're building the MVP, it can inform certain things or certain questions. I just find where having an expert or a person in the field or your customer, your ideal customer during the brainstorming session can save a lot of time with building a product that they may be like, well, we actually use this, or do this now. So how would this do this differently? And having those questions and challenges or how they actually currently do their work and where there's gaps in real time while you're building out your MVP is golden.
Absolutely.
So if there's a way we could do that in our next upcoming session, having like some type of person who can sit in as an expert that would be your ideal customer or the client ideally that you would want to present this to, kind of just being able to offer feedback as well.
Sure.
Hey guys, sorry, I know Dr. Henya has a product upcoming. Dude, I got a product now, and where's that brainstorming session? I need to tap in on that because I got a product right now that I could use some brainstorming out there right now. It's a telemed application, and what's happening right now is that it's become ubiquitous. You know, there's a lot of it out there. And what I'm trying to do is I know that there is opportunities to leverage because a lot of them started free AI craze and they're not leveraging that, right? But I'm coming in with that lens along with you guys that can say, hey, how do I take this product from, you know, a regular telemedicine platform to a brand new thing? You know, I'm not trying to necessarily come up with something no one has, you know, like something, you know, whiz bang. I'm trying to serve a need, but I'm trying to leverage AI to exponentially take some market shares or to be able to get to the value quicker, right? That's where I'm coming. I have a product that is, you know, it's cash-based. I'm trying to serve the underinsured and the non-insured. That's my market, right? People that don't necessarily want to pay $300-400 or have the money to pay for deductible. They just want to, they have an illness, they want to pay cash for it. Like I have this lump in my in my head or whatever the case may be. I just want to go see a doctor. It could be the guy at Home Depot. The Mexican at Home Depot has no insurance, but can't go to the hospital because it's going to be a high bill, but wants to see a doctor that says, hey, man, what is this thing on my forehead? Or what is this thing that I'm feeling? And the doctor will say, oh, yeah, you either go to the emergency room or, hey, you can take this medication and you'll be all right. But that consult is only $45 versus hundreds of dollars that they would pay, just to see a doctor and schedule, a meeting or whatever, or consult, right? So I'm trying to serve a need for a specific market, and I want to leverage AI because it's getting crowded. And the way to beat that crowd is to leverage the power of AI to be able to beat that crowd and go directly to who, so I'm spending a lot of money right now on Google, analytics and trying to get targets. And I haven't been getting any clients, right? You know what I mean? I haven't been getting that. So I'm trying to brainstorm right now. I got product in flight, launched a couple months ago. And all I've been doing is spending money on Google ads and trying to get a market share that is elusive right now. So, hey, if we're doing brainstorming session, I'm in.
Well, I'm curious, who's your ideal customer, if you were to describe them, what are they generating as far as income per year? What is their kind of like, what kind of work are they doing? Like, who is if you were to shape that the customer persona, who would that be for you based on the product that you're?
So, for example, for one, my platform we don't have an integration with insurance carriers. So even if you had insurance, I'm not doing the billing piece, right? My target is folks that, maybe folks that don't even undocumented for one, could be one part, right? It could be college kids, college kids that are in dorms that, they might not want to go to the doctor or go to their family doctor to say, oh, Dad, I had, let's just call it what it is. I had an STD. I had an STD. I don't want to tell mom or dad, but I want to go to the doctor and give me, what is this, medication for herpes or medication for chlamydia or whatever the case may be. But I don't want anyone to know, but I want to see a qualified doctor and I want to pay cash for it. I don't want to bill my insurance because I don't want my parents to find out. So there's different personas. So when I say underinsured and uninsured, it's really a target. It's not for folks like people that have Aetna and all these type of services that they, deductibles and family, whatever the case may be. It's for people that are really underinsured or uninsured is my target, So
and it's almost like a discretion. It's discretion based as well. So it's being able to ensure one's privacy, whether you're married, single, or child. But typically, sometimes those health records and those things get blurred. Those lines blur when there's in marriage, it's spouse or child. And so having this level of discretion can allow a person to maintain that privacy when addressing their health needs.
Exactly, 100%.
The one thing, I wanted to add something quickly. That's an amazing product, but you might the challenge that you seem to be facing is one that we see in product. And Josh will start off by asking the perfect questions. And this is what we do in a discovery thing. My biggest thing is, and it would be great to do a brainstorming session, because the bottom line is this: you have to commit to a cohort. A lot of times in product, what people understand that their product has reach in multiple domains, and that's a good thing. But when you commit to a cohort, you can do all of your analytics spin on that cohort and find out irrefutably if it's not working. You see what I'm saying? You could know, okay, process of elimination, that group isn't going to work. Or you may find out that group does work. Plus, you can validate that group from the perspective of opportunity size. If that group works, but they're small, then that's not going to work. You see what I'm talking about? So you're not throwing darts blindfolded. So it's you commit to a sufficiently large cohort and you start drilling. That's going to get you more for your analytics spin.
That's a great point. We started casting a wide net, just to see what we attract. And my analytics is telling me that it was a lot of, funny enough, men with ED. They were hitting up 90%. At one point, it was 90% of everyone that touched our application were male looking for erectile dysfunction sort of help, right? And then it's kind of spread out, and I'm like, okay, is that I'm trying to decide, is that my niche market? Because that's not what I really intended it to be. I was looking for more, not just male, but a broader range, because I don't know how much I can tap into that, because we have these huge, guys like Hims and all these guys that are basically saturated markets. So I'm stuck in a place where I started off with a specific group in mind, but right now my analytics is taking me, kind of left to right, and I'm trying to figure out who do I attract, who am I going to attract and sink in, because that's where you really gonna
experiment, experimentations. You got to experiment, and you got to what you do is, if you came to, let's say, the group and you had each of these cohorts laid out. My first question would be the size of the cohort and the potential. See, you have to take, and pardon my language, guys, you have to be a sociopath about it. You can't be married to any group. You can't really care. It could be any group. And then when, let's say, guys with, the ED, that's fine. Okay, what's the opportunity there in terms of delivering the product? What examining that group and experimenting deeper with that group to find out. It may very well be that's your jump start. Just because they're your jump off or your jump start doesn't mean that that's where you're going. But you need a sufficiently large cohort to validate your product, call them your early adopters, and from there you can start tapping into others. You see?
Awesome. No, that's good. I will take that back to the team. This is awesome stuff. What is my cohort, and what is the size of my cohort, and then experiment.
Yes.
And it's quite common. It is quite common for startups to pivot. A lot of the startups in my angel portfolio, they start off with a great idea. They're almost married to the idea, but then you look at them a year later, 6 months later, they pivoted once or twice or three times until they find that spark.
Gotcha. Yeah, it comes with a lot of capital, though. That's the thing.
Right. We don't have that to play with a lot of times. So
one other thing, what's coming to mind is also from the experiment group. It sounds like if you're the group that may be made up of primarily folks that are curious or experiencing erectile dysfunction, partnering with what's the name of the doctor for men? I'm at a loss. Women have a gynecologist, exactly. So
urologist.
So having urologists as partners would be able to help with the marketing, same way pharmaceutical companies would approach doctors to be able to market or prescribe certain, medication. The second is, I think a university would be a great place because, to your point, the discretion and just youth, let's just think about behavior and first time being free and poor decision making. That sounds like there's a lot of guys that'll be in the office or the lobby with their head in their lap or hands in their head because of a poor decision or whatever, and they trying to figure it out. And so that discretion. And I'm also say it's almost like the Ashley Madison crew, which nobody may want to acknowledge, but I can tell you, my mom used to work at Patient First, and there was a whole bunch of cases and stories of married or folks or relationships where folks were coming in trying to get stuff situated because and they were trying to figure out where's the mail going to go and where's this going to land and where's the bill. And so I think you have probably a huge market with just people wanting to maintain discretion. Passport bros are probably, you might want to catch cats when they coming back from their trip. But there's a whole line of, I think, where folks will be like, yeah, this is necessary across the board.
That's perfect. I just need to figure out how to find those guys. Like, I mean, when you say a university, I'm not just running up in a university and be like, hey man, I got this product, I want to make it, something that your students can access, right? I'm not even charging a subscription fee. That goes to show you how I'm trying to get into the market. I'm not even charging a subscription fee.
Have you considered, well, and that's something that hook up with me on LinkedIn too, because I want to talk to you more specifically about your approach to these experiments, because those experiments should be cheap. They should be cheap, and they should be able to deliver enough evidence to merit you moving forward, thus getting more money from your spend. And the other thing is, when you're doing this, the second step is engagement. So how do you actually touch those people? We use surveys. There are different ways to do that through Google Analytics to anonymously get people to, you know what I mean? And then there are other ways through partnerships, etc. But again, it should be very cheap. Okay, it's growth hacking. It's just you use these very cheap things to find out your cohort, find out, get with a university, partner with a university, student health at a university, and say, listen, we are a tech company that does XYZ. We want to partner with you. We want to ask surveys or what have you. There's a way to do that.
I'm going to tell you one
small
thing.
advertisements.
To do what? So to reduce the spread of STIs on campus, or to where the startup company that does this
value. What's the value?
Right.
Yes. Yeah.
So
to reduce. Okay, thank you. This is great. This is great.
You got to speak value.
Yeah, and what I'm hearing a lot of is, look, you guys are brilliant. I can tell across the board, but from the initial doing your pilots and things like that, it's just going to be an execution process. I don't know, I forgot who it was that was saying they were coming back next week. But what I'll do is I'll put you guys just the same thing that we use, whether it be M&A, whether it be BAU with the banks, how we actually kick off a product or kick off a project. And you follow that process from your communication plan to that stakeholder analysis to doing your low-level design. We'll have all that set up so that as you guys are doing your experiments, as you're doing your research with how do we apply these or how do we actually get these things done, you have a framework so that you can actually do what you focus on that. And then you've already got that structure there. You're continuing to follow this structure, and we'll talk about this a bit next week. And I'll bring some materials that I'll share with you all that'll help you all with getting started.
Sounds good, man.
Right.
I
So,
appreciate it, guys.
so next week, how do I pronounce your name? Is it Emeka?
Yeah, Emeka. I actually hit you up too. We're supposed to be connecting soon. Dr.
Yeah,
Jacob.
I saw that.
You saw that, right? Yeah.
Yeah, so I'll hook up with you for sure. It's been a long morning.
Yeah, I
I
appreciate
saw
it.
two
Man.
hands. I saw Stan had his hand up, and then Dan said something in the chat as well.
So before Stan talks, I just want to say, so next week we'll have another talk. Then we'll give 20 minutes to Dr. Inya, and then we'll give it 20 minutes to Emeka. So
Good, man. I really appreciate it.
Yeah, hey guys. First off, great conversation. I think that we're pretty much coming up on time right now, so I'll keep it short. So number one, Emeka, back to your point, I think one of the things that you're going to want to do is have someone on the public health side of the conversation. I think Dr. Enya's, got a really good sort of perspective, and I can see his kind of brain going crazy with the notion of, I mean, anytime you create a scenario where you've got health data circumventing the system of health record keeping, folks are going to go crazy, about that. So you're going to need to answer that question first and foremost. And frankly, there may be sort of avenues, but you want to do it in a way where public policy folks are not going to come at you, looking to cause. So Dr. Ian knows what I'm talking about. Yeah. So that's one. And then two, yeah. And then two is, at the end of the day, right, I think, if I had to sum it up, it's you coming up with a hypothesis. That's it, right? You come up with the hypothesis, and then you really have a tight hypothesis, and then you're testing against it, right? To see, where and how you kind of fall out from that perspective. And then on Dr. Inya, just, some thoughts for you. I was doing an equity project some years ago for a big pharma firm. One thing I'll say is when I was listening to the concept that you were laying out, one thing I'll say is that a lot of folks are not thinking beyond the data sets that are like obvious, right? In terms of public policy, health, et cetera. I would encourage you to also kind of broaden the scope to think about pulling in data from search engines, pulling in data from social media, right? Pulling in data from food deserts, right? What about food deserts? What about health deserts? What about transit deserts? I mean, all these different other data sets can help create a type of correlation and understanding causation that ultimately lead into a lot of what you're looking to kind of help clarify as well, right? Especially from the Black community side of it. So I would just encourage you to just be thinking about just broader data sets and harnessing AI's power to really crank through those data sets at a speed and a pace that really is unmatched, till recent times. But I think just from the work that I've done, you'll find some really interesting correlations out there that you would have never realized, right? Had you not looked at some of these other data sets that folks just normally wouldn't even think about, right? So just wanted to add that as well.
Thank you.
And that's it for me. Thanks, guys. Great conversation.
Yeah.
Thank you.
So Stan, we're not doing anything illegal with the patient data. Just to let you know, we'll get in trouble out here, But we're basically, it's protected. We're on the AWS platform. We got the certifications. We PII data, PHI data, all that stuff is intact, bro. So when I say that, I'm just trying to cater to people that don't want to necessarily go and get in trouble or to get exposed, so to speak.
Yeah, I get what you're saying, and I'm not talking about it from a PII perspective. I'm talking about it from the perspective of just how, from a public policy standpoint, there's just a whole kind of thought process around making sure that we maintain access or insight or visibility into a certain amount of health data so that folks can make those big, broad kind of decisions and perspectives, or make those big, broad policy-based decisions that end up affecting everybody ultimately. So anyways, that's all I was calling out.
Hey, Stan, you just killed my whole crypto health idea.
Yeah, I'm a student on HIPAA and
Exactly.
PPIs, PHIs. So yes, so we can figure that out.
And I'm gonna hit you up, man. Let me see if I'm make sure I ain't doing nothing wrong from a public health perspective. You know what I mean?
Yeah.
I don't think so, but we're right.
Yeah. It's all about having different perspectives at the table to help think through all the spots. That's all.
Yeah.
All right. Cool.
All right, guys.
Thanks, guys.
Appreciate you.
Take care, man.
All right, guys.
Okay.
Everyone.
Have a good one.
Bye.